I've been working as a clinical researcher. And perhaps one of the domains where my main interest is the Charcot foot, and I will be talking on this on Friday, I think. But in parallel to this, I've also been involved in some work with thermal imaging, and I would like to talk about this today. We've already heard that the diabetic foot is a major complication of diabetes. It is associated with significant reduction in quality of life, morbidity, and mortality. And there is a high recurrence rate, which we need to prevent. And because there was a question about can we prevent ulcers, I think the very first ulcer is quite tricky to prevent, and there is actually not a lot of information how to do that. And as part of, within the diabetic foot study group, there is a new initiative where they have gathered a group of young scientists, and they're working actually on a project how to prevent the very first ulcer. But if we can't prevent the very first ulcer, we really need to try and aim at least to prevent ulcer recurrence. And for this, it's very important to know the natural history of the diabetic foot, and I will present in a pictorial way the progression of the high-risk neuropathic foot. It is a foot with deformity, which can become ulcerated. Ulcers become infected, and this can lead to necrosis. And it is really important to try and stop this process. And I know there will be more information about different methods, how we can prevent ulcer recurrence. I think the pathogenesis is multifactorial, and therefore we really need to account for various risk factors. But it seems that one of the techniques which has been raised a lot of attention recently is the hypothesis that the foot heats up before it breaks down, which was actually put forward by Paul Brandt. It is associated with a rise in skin temperature before an ulcer occurs. And therefore, if we can identify this with a measure, we may be able to identify areas at risk of possible skin breakdown and ulceration. And for this, there is some early research done by Lavery and Armstrong in America, and these studies have been carried out with a touch thermometer. I apologize, this picture is from internet, which is in relation to show the instrument measuring a foot in a Charcot foot, but actually they use this instrument, temp touch, which is an infrared thermometer, and they use predefined areas where they ask people to monitor temperatures at home. And these two studies has shown very promising results, showing that in the enhanced group, where patients had a standard therapy, which was foot therapy and home temperature monitoring, they showed a significant reduction in ulcer recurrence rate. There've been further work carried out by two groups, one in Norway and a recent study published by Psycho Bus Group. They used the same thermometer and they showed that although these patients who were assigned to the intensive group of temperature monitoring, they did not show a significant difference or reduction in ulceration rate. But when they carried out further analysis, it was interesting to find out that actually foot temperature monitoring only worked when patients were compliant and when patients reduced their ambulation and their activity related to the reading of the instrument, and also when they were using protective footwear. So we need to be aware that technology can only work if obviously it's supported by other systems. I don't think we expect that we'll have a machine which will really take the care out, and we rely only on measurements. A further development, this is a temperature map, smart map technology. This is a study published by Frickberg in Diabetes Care, where they assess the usability of a thermal map. You can see a person standing on the temperature map, which is taking images which are then saved in the cloud. And they actually noted that almost in more than 5 weeks before the skin breaks down, they noted an inflammation and an area which was vulnerable, and they assumed that this and put forward that this type of thermal measurement is really promising to reduce ulcer recurrence rate. But we need to be aware that foot ulcers do not only occur on the feet, they also occur on any part of the foot. And this is the schematic representation from data from Eurodialy, which was a study in Europe, more than 1,200 patients from, I think, 10 countries, but I will need to double check this to confirm. And in this large cohort, they reported that more than half of the foot ulcers have non-plantar location. So if we go back to this technology, it seems that we will be able to pick up underlying inflammation in only half of the cases. So therefore, there's been put forward that perhaps we need a different type of technology which not only takes pictures of the plantar feet, but also allows us to take a picture of the whole foot. And I will tell you in the next part of my talk about my involvement in working with the National Physical Laboratory in London, a group of physicists and temperature scientists, and within a study funded by the National Institute for Healthcare Research. We were working together to develop an instrument or technology to capture thermal images of feet. And this is the prototype. This is a clinical, this is a research device, not device for clinical use. And this was a collaborative project. It was led by us at King's in collaboration with colleagues from Manchester and Newcastle. And also we had the support of National Physical Laboratory, and also Photometrics was a company that was helping with the device. So to assess the technology first, we carried out a clinical trial in healthy individuals, and we compared the reliability in temperature assessment of an instrument with a handheld thermometer, and within the healthy volunteers, we assessed 33 different regions on the feet, plantar, dorsal, medial, lateral malleolus, and also we also assessed the repeatability of these measurements within 5 different spots. And here is an example of a thermal image where the colors represent or show representation of different temperatures. This is an example of healthy feet. They look rather symmetrical, and also with the device we were able to identify different regions of interest and compare temperature differences. And within this first study, we reported that there was a very good instrument agreement in repeated measurements by the instruments, and also we showed that there was a very good inter-instrument agreement between the handheld thermometer and the thermal imaging device. And within this study of 105 healthy volunteers, we also developed the acquisition protocol. We were interested to have plantar, dorsal, medial, and lateral images to be able to assess the whole foot. And then we utilized the technology and carried out a clinical trial. And this was a multi-center study. It was single-blinded, and I'll explain how we did the blinding in a minute. And in particular, we were interested whether this clinical instrument, in addition to standard care, can reduce ulcer recurrence. So for the study, we looked for people who have had a past history of foot ulcer. They were required to have intact feet for at least 3 months. We were not sure what will be the post-healing thermal image of a person who have just healed an ulcer. So this is something which is unknown, whether there will be protracted vasodilatation with some heat or not. So therefore we wanted to have people healed at least for 3 months. We included people with neuropathy. They were required to have palpable foot pulses, and they all were required to have appropriate footwear. We excluded people with sharper foot or deformity, which is either related to previous surgery, and also we excluded people with implantable electronic devices. And for this study, we used the instrument and took plantar, dorsal, medial, and lateral thermal images of the feet with the device, initially at 10 minutes after the patient was rested on her podiatry chair, and then repeated at 20 minutes. The device not only took thermal images, but it also took visual images. And for the purpose of the blinding of the study, the study device was set up at the visual mode, and only the researchers were able to see the thermal images, and the patients didn't know whether we actually treat them on the basis of thermal images or only on the basis of clinical presentation. So we randomized the patients, and the intervention group was thermography and usual care, and the control group was blinded thermography and usual care. And usual care consisted of callus debridement and pressure offloading, and routinely these patients are seen every 4 weeks in a clinic. And at each visit, for those patients who were in the active group, in addition to the clinical treatment, we also assessed their thermal imaging secretly in a different room. So we were always leaving the room when we were seeing the patients, and now we need to have a little consultation and come back. So they didn't know whether we treated them on the thermal images or not. And then if we identified areas which we thought are pre-ulcerative, then we protected them and improved offloading, and also seen patients more frequently. So patients in the study were followed every 4 weeks until ulcer recurrence, or 12 months. The study did not show a difference in ulcer recurrence at 12 months in both the univariate and multivariate analysis, and also time to ulceration was not different between the two groups. And perhaps the easiest to present is this Kaplan-Meier survival plot, which shows the proportion of people who remained ulcer-free on follow-up. So this was a 12-month follow-up, and you can see that in both groups there was ulcer recurrence, and perhaps the study was not long enough to show this initial separation, which we were able to see just as the study was progressing. So with this study, we concluded that perhaps monthly intervention with thermal imaging is not sufficient to protect patients from ulcer recurrence, and this did not increase the longitudinal ulcer-free survival. Indeed, it is very difficult for one image taken in a clinic to predict what can happen in the next 30 days. And therefore, And what I would like to present is some data from the blinded group. So what we did was, so from the patients who we randomized in the control group, we also took thermography in addition to standard care, but we unblinded the images after the end of the study, and there were 34 patients in the control group and 15 patients remained with intact feet. And we were quite interested to see how these thermal images progressed over the 12 months of these patients. It seems that if we only look for hotspots, there was increased percentage of patients with at least one hotspot on the plantar side on these 12 monthly follow-up visits. And also there was some variability. So we were able to see these thermal images at the end of the study, and they are monthly thermograms of a person who did not ulcerate, and you can see that they can vary quite a lot. And perhaps particularly in this case, you can see a typical, or there is a hot spot in the fifth toe and a hot heel, and we did not have any different intervention because we have not seen these images, but nevertheless, the person did not ulcerate. And when we looked into all these 33 regions, which we evaluated on the thermograms, we've seen that there was presence of different regions of interest, which showed increased temperature difference. So perhaps it's really very important to interpret this information, and I think we need also to understand that a single thermal image which shows a temperature difference, of 2.2 degrees, which is perhaps the threshold associated with ulceration, is not sufficient, and we show that quite a lot of patients had variable hotspots in their feet, but they did not always lead to an ulceration. And therefore, it is very much encouraged not only to do thermography in clinic, but obviously we would need to repeat these images in order to evaluate which are the true hotspots and really pick out these false positives. And with this study, we also wanted to push the boundaries a little bit because I think there's been a lot of focus on plantar thermography, but as I mentioned, ulcers not only occur on the plantar foot, and actually I would really like to show you a case where we have been able to preview the thermal images, and I will give you a little brief history. This was a person, 67-year-old with type 2 diabetes, obesity, had neuropathy. He had a history of a chronic left sharp foot and also history of foot ulcers. So he was healed and was monitored in the study. And in one of the clinical presentations, he came to clinic. His feet did not show any signs of inflammation. The skin was intact. There was no redness, no swelling, and he had claw toes bilaterally and some deformity of the first foot. He had palpable pulses, but on clinical examination, he really didn't have any indication of a possible injury. This is an example of the thermal images. So you can see the plantar, the dorsal, medial, and lateral. And on the left foot, you can see this red hallux or hot hallux, which was reddened and inflamed on the thermal image, but on clinical presentations, there was no real indication of abnormality. And you can see that this hot spot was detected on the plantar, dorsal, medial, and lateral image. At the close observation with the podiatrist, we were not concerned about plantar lesion, but actually it turned out to be that we assume that this is pressure from a thickened nail, which is causing this inflammation. And this type of inflammation is not really possible to pick up with a normal eye. And this is exactly the place where thermography can help us to really reinforce or perhaps guide findings on patients' feet. This close observation, we did a nail wedge resection of the nail and reduced the thickness of the nail. And then you can see that 2 weeks later, this pressure and inflammation has resolved. So in this case, I think we prevented this ulceration guided by thermography. And to conclude, it's good to have technology which can really be helpful and adjunctive to clinical information. I think at present, monthly thermography is not sufficient to prevent ulcerations, or at least that cannot be proven in a study, because a lot of things happen over 1 month. There are traumas, and for this study in particular, we did not separate between traumas or non-traumatic ulcers, and perhaps this is something which needs to be considered. And also, we have also made some conclusions that perhaps plantar thermography is not sufficient to detect risk of ulcerations. And I demonstrated the usefulness of thermography within a clinical scenario and within a clinical presentation. And I think it's a very useful adjunctive clinical tool. And perhaps the way forward in future would be to combine this, to combine clinical thermography with some sort of home temperature assessment for improved detection of areas at risk of ulceration. Thank you.